There we go. Oh. Excellent. And can you see the right screen? Okay. All right. So immunology. In general, this will be a 50-minute class every Wednesday from 11 to 12. We'll always do it via Zoom, and then I'm going to try and archive it. I have a YouTube site called @312 Immunology that I started years ago that have 10 or 15-year-old versions of this from when I was doing it for the fellows at Children's Mercy archived there. So I'm going to make an attempt this year to add these to the archives. I failed last year. The lectures are meant to complement but not replace the reading. The really important part of the reading is the really important part of the lecture series is to do the reading because it is essential to pass the boards. There's just absolutely no question about it. So the lectures will complement that. And I try and pull out the things that I think are high yield and you really need to focus on and remember. But the lectures alone out of context of what you've read will not make sense. So do your best to keep up. I'm going to try and make sure we have plenty of overview. If anything, give you more time and not times when I'm surprising you with moving everything up. Zoe, do you have the books for the year? Were you able to get them? Did Carolyn get them for you?
I have this just from like purchasing it on my own, but I wasn't given anything else yet.
Interesting. So this is the Sympyric text. Carolyn was looking. The problem is the bookstore changed over this summer from like, I don't know, it's like Barnes and Noble to Follett's or something like that, and it kind of disrupted the hiring process. I may ask you to order it from Amazon, the text, and just submit the receipts to Carolyn for both books for reimbursement, if that's okay.
What edition is it?
I have the 7th edition. Get the most recent one.
Okay, yeah, I have the 6th. So.
Oh, I'm sorry. For Sympyric, it's the 7th edition.
Okay.
And then for cellular in the Abbas edition, I had 10th. It looks like you have a newer one than that. Do you have 11? Or is that an older one?
The one that I have is the Sympyric.
Oh, that's just the Sympyric.
Yeah.
Got it. Yeah, order the update one for both the Abbas. I think Abbas is on the 10th edition, and I think Sympyric's on the 7th edition.
Okay.
And then just, yeah, give Carolyn the receipts and she'll get you reimbursed. Sorry about that.
That's okay.
Okay. The big thing is when you go through this the first time, Megan could probably attest, it doesn't make a lot of sense. It feels like you're slogging through and you don't remember anything. And then you purposefully repeat the curriculum twice because the second time through, all of a sudden you start to realize that you picked up way more than you thought and it becomes way, way easier. So just trust the process and do your best. But by the time you've gone through this twice, in general, you are going to be fine. There are things you're just going to put on note cards and memorize, of course, but once you get the concepts down, that memorization becomes much, much easier. Did you read Sympyric again, Megan? And did it resonate the second time through? Is it starting to click in a big picture?
It definitely is, but I really like Sympyric as well. So
I do too. He lays it out so nice and easy. That's why I try and start with it, just to kind of, just get things started on the right track. Like, yes, this is manageable. I can't understand this. And then dive in to the nitty gritty. I still have 3rd edition on here. How the Immune System Works is now on its 7th edition. I think I've been teaching this since the 1st edition of Sympyric. It was the 1st or 2nd edition. Abbas, and then we're not going to do Janeway this year. I have a big year ahead of me, but I'm going to try and start going back and forth from Abbas to Janeway at some point because I think there's some benefits to going through both. And they're very similar, but kind of changing up how it's explained. I kind of liked personally, so that's for the back burner right now. Okay, so first year. just try to learn the key concepts. That's really the important part. Don't memorize the details. That's not the focus for this year. It's really just looking at the big picture and thinking about clinical relevance. But second year, Megan, it's your time to start memorizing the details, making sure that the key concepts are a review at this point and starting to really commit those to memory. Make note cards so you have, like, the month before board, something to refer to and go over with. Really try and start applying the basic science to clinical disease. We never got to an immunology lecture last year. It's just more complicated now than when I was doing this 10 years ago, because there's so many more identified diseases than there were back when I started. But yeah, getting to know some of those clinical diseases is going to be key. They have been making strides in the past few years to make the boards more clinically relevant, but what that means is they pick out immunology that is associated with clinical immunology diseases. So that's a little tricky. Okay, so the expectations I have for me is that I'm going to make sure you have a lecture weekly. It doesn't end up being weekly. It's probably more like bi-weekly. And then after we do a set, I'm trying to review. We did a test last year because it was just Megan, which I know isn't fun. In the years past, I did a Jeopardy, but since there's two, maybe we'll try and go back to that. I don't know if it'd be too intimidating, just you two playing against each other. I used to have more fellows, so it was a little bit easier to play Jeopardy, but I'll give that some thought. Excuse me. So expectations for you, please read before class and then be in Zoom at 11, and then do not play on your cell phone or other things on the computer during the class, please. Okay, so today is just a very, very general introduction. It's the same lecture that I give to the residents every year, every other year. You may have heard it before, but I'm just trying to highlight the big picture of how the immune system works to complement the empiric text. And then we'll get into a little bit more of the nitty-gritty details that empiric points out next week when we meet. Okay, so what gets the immune system started? So pretend you step on a splinter, you're walking outside, and that splinter, of course, has microbes on it. What happens? There are three sentinels of cells that just sit in your periphery. They're not in your circulation. We know they're not in your circulation because if you do a CBC of your white blood cell, when do a white blood cell differential, you are not going to see these cells there, but they're key players in the immune system. And there are three. Any idea what any of those are?
Macrophages.
Perfect. Yes, macrophage, exactly. And the original one, this is usually the one we forget about, but this is, I would say this is one you tend to forget about as a resident, but as a fellow, you need to keep in the forefront of your mind, one that actually initiates the whole immune or inflammation pathway.
Either dendritic cells or APCs, not sure.
Yeah, those are the two terms for the same
Okay.
The same cell, and you have absolutely figured out what makes immunology hard already in lecture one. It's because there are several names for the same thing. So I try and point that out as we go along to minimize the confusion. But I always call immunologists assholes because they take cells and they give it 5 different names and they make it super confusing. But if you just kind of focus on the cell and know the names associated with it, it makes it a little easier. The last, of course, is the one that keeps us in business, mast cells. Macrophage, I like to point out from the beginning, is the worst. It has a million names depending on what organ or what epithelial lining it's in. It's Kupffer cells in the liver, for example. I usually say, if there's another name for a cell that you don't know, it is probably a macrophage. Most of the time, that's correct. Histiocytes, I mean, it's all slight variations, but just to kind of lump it into a type of cell. Okay, So what happens? The dendritic cell, it is the first thing to act. So you get your splinter and the dendritic cell eats that microbe that it sees. And once it does, it engulfs it. It hops into the lymph. And when it hops into the lymph, it travels to a lymph node. And this is where it engages the adaptive part of our immune system. So you're going to hear broad branches of the immune system. And in general, there is the adaptive immune and the innate immune system. So adaptive, anything that's adapted, anything that's changed. So what is changing for this nomenclature is the DNA. So anytime a DNA has rearranged, then that is the adaptive immune system. So the two times that happens are in T cells and B cells because these are antigen specific cells. So we call anything to do with T cells and B cells the adaptive immune system. And then things like neutrophils, which have no rearrangement, no adaptation, you're born with it. Those we call the innate immune system. Within the adaptive immune system, you can have T cells, which we will also often refer to as cellular, even though B cells are cells too. In the B cell side, we typically refer to as the humoral immune system. The reason for that is B cells secrete antibody. Before we knew what antibody was, they knew that if you took the serum from one person who had previously survived an infectious illness and gave it to another person, that other person stood a better chance of survival. And they said it was because of the good humors that were transferred from one person to another person. But it turns out those good humors were just antibodies. And so anything to do with antibodies or B cells from then forth became known as the humoral immune system. Okay, so back to our pictures. The dendritic cell is in the lymph node. And this is a very important key point and one of the most important key points as you think about the immune system that you're ever going to get. The dendritic cell activates a T cell and it activates a T cell first. Once that T cell is activated, then it travels outside the T cell zone of the lymph node and goes toward the B cell side of the lymph node. And we'll discuss how that happens, how it is able to travel. But once it's at the B cell side, it finds a B cell that can also recognize the same antigen and it activates it. That B cell cannot activate if that T cell was not activated. Therefore, if you have no T cells, it does not matter if you have B cells or not, they can't work. So if this part of your immune system for any reason has been disrupted, what immune deficiency do you have?
Kid.
Exactly. Severe combined immune deficiency. It is combined because neither your T cells work or your B cells work. You can have a humoral immune deficiency. That means your B cells don't work. If it's a severe combined, or just take out the word severe, if it's a combined immune deficiency, a CID, you have no T cells or your T cells are non-functional. It does not matter if you have B cells or not. They can't activate because T cells have to be activated first. So what happens next? Once the B cells are activated, they're going to hop into the blood vessels. It does that by continuing through the lymph system and eventually going to the thoracic duct, which plops into the vena cava, so these can re-enter circulation. Once the B cells are activated, entering the circulation, they go back to the bone marrow to reside. And in the bone marrow, they become plasma cells where they secrete antibody. IgM, IgG, IgA, IgE. If this part of the immune system is disrupted, then you have a humoral immune or an antibody defect. And here it gets a little bit more confusing. I actually took out my skid slides. I should have left those in. If you have no B cells, then of course you have no immunoglobulin because there's nothing there to make the immunoglobulin. And of course you have no response to vaccines because the vaccine response we look for are specific antibodies, tetanus IgG, Hib IgG. If you have none of these, then you have an antibody deficiency that is Bruton's A gamma globulinemia. It's X-linked. But this arrests the development of B cells at the pre-B cell stage, where there's no Bruton's tyrosine kinase, and we will review that again yet this year. There is also a autosomal recessive form of this. That's a mu, I think it's a mu heavy chain. It's called mu heavy chain deficiency. It is more likely you're going to get tested on the autosomal recessive form as a fellow than the more common X-linked Brutons. It is more likely on the PEDS boards you're going to get tested about Brutons. Okay, there is a disease, however, where you are making B cells just fine, and we can find those, but if you do not have any but for whatever reason, the B cells are not making immunoglobulin, and the reasons why are a little bit less well established, although we have some genetic defects that we can tell drive this. If you have no immunoglobulin, you also are not responding to vaccines, of course. If you have no IgG, you can't have any tetanus IgG. If this is the pattern you see when you're working this up, you have common variable immune deficiency, which is, for us, the most common immune deficiency that we treat. Of all immune deficiencies, the most common is selective IgA deficiency. So you're not low in all your immunoglobulins, you're just low in IgA. But the clinical consequence of this is really unknown. We don't tend to treat it. We tend to kind of shrug our shoulders. We tend to let patients know that if they have no IgA whatsoever, that they need to be careful if they needed a blood transfusion because they may have anti-IgA antibodies that would make them anaphylaxed if they received IgA, if they're IgA naive. Selective IgA deficiency is common, but ones who have zero IgA is incredibly uncommon. We just don't see it that much. In fact, we have to do a send out to Mayo to even get a level low enough to see if they have any at all, because our lowest level detection, I think, is like 10 or something like that. And I think Mayo is the only lab I know that goes lower. And then there's something called hyper IgM. So hyper IgM, of course, IgM is the first antibody we make, and then switch is flipped and IgM goes to IgA or IgG or IgE. If your cells cannot flip that switch and change from IgM to GA or E, then you just keep making more and more IgM. It's not a very effective antibody, so you make a lot of it and you still remain sick. This is called hyper IgM syndrome. But your IgG and IgA will be low. So you have a phenotype that is similar to common variable immune deficiency because you just don't have the IgA, which is by leaps and bounds the most effective antibody we have. Okay. And then there you could have a phenomena where you have plenty of B cells, you have plenty of immunoglobulin, but you are not responding to your vaccines, and in particular strep pneuma. That's why we pay so much attention to it. It can be very hard for us to respond to strep pneumo vaccine. Pneumovax in particular. This is called specific antibody deficiency, and there's different levels of severity that we try and kind of muck around with and decide. There's not clear guidance of when we treat this and when we don't. I try and make it kind of clinically relevant. So if the patient is sick a lot and they're antibiotics a lot, then I'd probably trial replacing immunoglobulin to see if it helps. Sometimes what's happening is they have CVID, but it's masked because they have an autoimmune disease that was at the same time creating one single IgG in a huge amount. Or maybe they have, I've seen this before, celiac disease. So they're making a lot of transglutaminase IgG, but they're not making any other IgG. So they really have CVID, but the way we're kind of sussing it out is by looking at the vaccine response. Okay, and then the last pattern you may see as you're trying to work this up is that you see B cells, their immunoglobulin levels are not gone, they're very low, but the response to vaccine is just fine. Most common reason we see this is transient hypogamma of infancy. Often it's a kid who is sick probably at the same rate as other kids, but maybe mom is more worried, or maybe there's just sick a little bit more, and a very well-intentioned individual gets immunoglobulins. We see this pattern, but we see it go away usually by 5 or 6, and we tend to not treat. As long as they're making good response to vaccines, we tend to just let them go the vast majority of the time. There's been a couple times that I've been tempted to treat, I may have even treated once with that pattern for a few years with the expectation that we're going to try and transition off. This is also a sign, this is we see on consult service, of acquired hypogam for some reason. Either they have a chronic post-viral phenomena, a metabolic disorder, nutritional deficiencies, alcoholics will see this pattern. The most common is that if we see a protein losing state of some sort, and this would be like kids who've had a Fontane's procedure who are dumping lots of protein. We glean this by actually looking at the protein level, albumin, and the immunoglobulin may just be another one of their proteins that's getting dumped, because the immunoglobulins are, if you think about the alpha, beta, and gamma bands, when we do a serum protein electrophoresis, we call them gamma globulins because all the immunoglobulins sit in the gamma band of that. So we can look and actually do an SPEP and look at the protein pattern. If they're all universally low and their albumin is low, that's just, they're in a protein losing state. Again, it all comes down to if they can respond to vaccines, it's fine. We tend to just watch them and not replenish. If we try and replenish and get their levels up, often what happens is they just dump what we give them. If we're not sure for whatever reason, you can actually do kind of a time study and give them a dose and see how quickly they lose all their immunoglobulin. IgG, the half-life is 3 to 4 weeks. So if you give IgG, you should slowly see it decrease after 3 to 4 weeks. But if it's all gone within 3 to 4 days, then you know there's protein losing. They didn't actually naturally metabolize that correctly. Okay, back to our pictures. So we know what B cells do. What do the T cells do? Same thing. They leave the lymph node eventually once they've been activated. They travel through the lymph until they can be dumped back into circulation. In circulation, they're going to travel to this, well, maybe they're going to stay in circulation. Maybe they're going to travel towards the site of infection. And T cells are going to act kind of like the quarterback, and they're really going to give direction to everybody else about what to do more than actively do something themselves. They're secreting cytokines to activate macrophages. It's going to tell macrophages, who are really a workhorse, to take care of this infection, to eat this infection up, phage to eat. So the macrophages are going to get activated. They're going to try and eat this bacteria that it was seen that was signaled danger through this dendritic cell. If this can't happen, then you may have a problem with your interferon gamma IL-12 access. That is probably one that's newer for you, but this is something that has emerged as a very important deficiency probably in the past 15 years. Eventually, though, the macrophages, remember, they're sitting in a finite amount in your periphery. They're going to get used up and they're not going to be able to continue the fight on its own. So macrophages call in another cell to help eat up the infection. So this is one that just sits in our circulation. We know it's in our circulation because if you draw a white blood cell count and do a differential of it, you can see it. What cell is this? It dives in to help macrophages with the infection.
Neutrophils.
Yeah, exactly. This is neutrophils. They jump in, they eat, they die, they become pus. That is their job. It is, anyone who studies neutrophils is going to say it's way more important than it is. but the simplified version is they eat, die, and become pus. So the neutrophils actually have to get there somehow because they just sit in our blood vessels. So what they do, they're flying through our blood vessels, and they actually have receptors on the outside that let them slow down and then adhere to the side of the blood vessel wall and sneak through. If this cannot happen, it is because you are missing a certain molecule on the outside of your cell. What is this molecule? If it cannot slow down, adhere, and slide through, you have an immune deficiency. It's leukocyte adhesion defect. So the CD18 molecule is the adhesion molecule. It's also a complement receptor. This adhesion molecule allows neutrophils to leave the cell. So if you don't, you may have a sterile pustule somewhere, or granuloma. It's not even a granuloma. What do you call it? I'm not saying it right. You would not be able, if you biopsy, to see any immune cells in the lesion that you have. So these tend to be things like on the outside. So you have gingivitis, cellulitis that the neutrophils cannot get to and help with. Your neutrophil count in your blood, so your neutrophils know they need to be doing their job, they just can't do it. So it tends to be that the neutrophil count gets higher and higher and higher and higher. So the first sign we see of this often is just on a CBC, and an infant will draw it and the neutrophils are very, very high. We treat them. It happens again, we look again, and they're still high. Sometimes it happens 2 or 3 times because you keep thinking, oh, well, they're sick, they're sick. But eventually, hopefully we'll clue in that this neutrophil count should not still be high. It should be coming down at this point, especially if they're hospitalized. It's because they don't have that adhesion molecule. They don't have that CD18. It cannot adhere. It cannot slide out the cells and support the macrophage. Okay. If the neutrophils can get to where they need to go, but they can't actually eat the bacteria. So what happens? So here is the bacteria that we have, or the dendritic cells have signaled are dangerous to our bodies. So it's going to see a neutrophil. It is going to get engulfed in this phagosome. The phagosome is going to adhere to a lysosome to make a phagolysosome. In this phagolysosome, just like what mom did, your cells are going to pour hydrogen peroxide on that bacteria to kill it. And that process will just continue. This happens, you generate hydrogen peroxide through something called an oxidative burst. If this oxidative burst does not work, you live in a state of stalemate where the bacteria don't die, but neither does the cell either. And you have a disease. Any idea what this disease is?
I think this is CGD.
Exactly. This is chronic granulomatous disease. So we test for it by getting an oxidative burst. The old-fashioned way was to do something called the nitro-blue tetrazolium test with a microscope. That was the dye we used that would reduce if there was an oxidative burst there. Now we use something called dihydrorhodamine, and the flow cytometer looks to see if the dihydrorhodamine has been reduced by the oxidative burst. If it's not that oxidative burst, it just doesn't work. On your tests, I think they've settled on the nomenclature oxidative burst. You may still see dihydrorhodamine or DHR on there. I don't think you're going to see nitro-blue tetrazolium anymore. Okay, but the other thing that can happen is you engulf into this phagosome, you have your lysosome, but this phagosome and lysosome cannot fuse together, so you can never get to the oxidative burst stage. These lysosomes also are responsible for pigmentation in our skin. So if this cannot happen, you have something called Chidiac-Higashi disease that is associated with partial albinism. Okay. Great. So that is in a nutshell what happens with the immune system. Now, say that initial invader was not a bacteria, but it was a helminthic parasite that has a really thick skin. And it doesn't matter how much hydrogen peroxide you pour on it, that skin is thick enough that it is not killing that bacteria. We need something else. And that's why mast cells are here. So mast cells will, when they are activated, they will burst open, activated by a T cell, probably a Th2 type cell. It bursts open and it releases histamine. And histamine is very good at chewing through that thick skin on a helminthic parasite. But just like the macrophage, mast cells will eventually get used up because there's a finite amount sitting in the periphery. So they need to call and help from something that is running around in the blood vessels as well. That, of course, also keeps us in business, like the mast cells and eosinophil. Let's see, so we've talked about neutrophils, we've talked about lymphocytes, we've talked about eosinophils, neutrophils, eosinophils, neutrophils. Basophils are a sort of a blood equivalent of an eosinophil, or a mast, I should say a blood equivalent of a mast cell. They're really poorly characterized compared to other cells in our blood. And then, of course, monocytes. And monocytes will come and replace these macrophages after they have been used up or they die off. But that is the vast majority of the cells of the immune system. The lymphocytes, of course, being TB and NK cells. We know everything that you could see in the bloods in our blood cell differentials. And then we have mast cells, macrophages, and dendritic cells. Macrophages probably with the most different names, dendritic cells also with a gob of different names like Langerhans cells, and mast cells tend to not. It's because allergists are nicer than most immunologists, I will say. Those are most of the cells of the immune system. So try and keep those just in a place where you don't panic if you see another name for a cell. Instead, if you see anything else that doesn't look familiar, just check and see if it is another name for one of these things that I've already learned in this lecture. Okay. Questions? Synpyrac, we're actually going to do all the way through chapter 7 next week. So try and get that reading done if you can.